Hello everyone and welcome to the Mental Health Commission of Canada's webinar series on integrating psychological health and safety in the workplace. Today's webinar topic is combating stigma in healthcare, what works and why. I'm Sandra Coppert and I'm a manager on the workplace team with the Mental Health Commission of Canada, and I have the pleasure of introducing today's speakers. Before we move forward with our speakers, I do want to acknowledge that we are using a new webinar platform, and some of our regular users, I know you're probably accommodating some of the changes, as are we, so hopefully you can bear with us and that things will be smoothly today and moving forward. And just before we get started with the speakers, I also just want to throw a few housekeeping items to everyone. The webinar is being recorded as usual, and it will be posted on the MHCC website in the webinar archive section following the presentation in a few weeks. All links discussed throughout the webinar are available in the what's called the web link section that you should see on your screen right now. Just click the link you would like to access and click Browse To, and this will open the new browser window. You can download the presentation, slides, and all the resources in the Files section. I invite you to send any questions or comments using the Q&A feature, which can be found at the bottom right of your screen. So for those of you who have joined us in the past, this was sort of the chat function before, and now it's Q&A feature. You can also use this if you have any tech issues, and we'll do what we can to help troubleshoot. Also, due to the large number of participants today, we have muted all of the microphones to eliminate background noise during the presentation. But you might want to go ahead and mute your phones or audio as well if you can at your end, but that's how it's set up for today. For today's webinar, first, Stephanie Knack will address stigma in healthcare and the work of Opening Minds. After, you will hear from Jennifer Kitts, who is the Director of Policy and Strategy at Healthcare Can. Jennifer is also leading Healthcare Can's efforts to level the playing field between physical and mental health. We will hear from Healthcare Can following Stephanie Knack about the joint efforts with MHCC and the By Health for Health Collaborative and the new Declaration of Commitment to Psychological Health and Safety in Healthcare. Jennifer will be joined by Sandy Coughlin, who is Director, Occupational Health and Safety at Providence Healthcare in Vancouver, BC. One of the members of the, one of the co-chair members of the collaborative. And Sandy will be sharing info on the newly released Declaration of Commitment to Psychological Health and Safety in Healthcare. And following that, time permitting, we will also be able to answer some questions. So to get things started, I'm very pleased to introduce our first speaker. Stephanie Knack is a research associate with Opening Minds, the anti-stigma initiative at the Mental Health Commission of Canada, and she's an assistant professor at the University of Calgary. She was a key researcher in Opening Minds' large-scale, multi-year evaluation study examining best practices and key ingredients for combating mental health-related stigma in healthcare. She has published widely on the topic of stigma reduction, and previous to her work with the Commission, Dr. Knack's research concentrated on maternal mental health. She holds a PhD in sociology from the University of Alberta. So now I'm happy to turn things over to you, Stephanie.
Thank you, Sandra. And hello, everyone. It is certainly a pleasure to be here with you today to be able to share with you some of the work that Opening Minds has been doing over the last few years. So just by way of background, as Sandra mentioned, Opening Minds is the anti-stigma initiative of the Commission. We started our work in about 2009 and have been going at it ever since. Now, when Opening Minds started, we decided to take an approach that at the time was quite a bit different from what many other countries were doing, which was implementing large-scale social marketing campaigns. We decided to almost go the opposite direction and take a more bottom-up approach. We really believe that this would ultimately have greater impact and also provide more value for the investment. And I would like to think that our efforts have really paid off in this regard. We are now in Canada looked at as very much a leader in stigma reduction internationally. Opening Minds actually won an award last year at the International Together Against Stigma conference in San Francisco for innovation in stigma reduction. So we're tooting our own horn a little bit there. So anyway, our approach was very much a targeted grassroots approach that was intervention focused and evidence informed. And when we started out, we identified 4 key target groups that we really wanted to go after: healthcare providers, youth, workforce, and the news media. And so today I'm just going to focus specifically on our work with healthcare provider populations. Now, the other thing we decided at the outset is that we really weren't interested in reinventing the wheel. So if there were already effective approaches and interventions and programs out there being used, we really wanted to help support and mobilize them. So our goal was really to better understand what was already taking place in the field of stigma reduction within healthcare environments, figure out what was working and why, and then really push to replicate and scale up those successful interventions and promote those best practices. So we did this primarily by working with partner organizations across the country. And we engaged in these partnerships with different organizations and universities that were implementing anti-stigma initiatives and basically undertook a large-scale applied research study where we evaluated all of these different programs. So one of the main things we had to do at the beginning was actually create a common metric that we could use so that we would have consistency across all of our evaluations. So we did develop a scale. It's called the OMSHC, stands for Opening Mind Scale for Healthcare Providers. And it is a scale that we designed specifically for healthcare provider populations. And just let you know that that scale is validated and it is in the public domain. So it is free for anybody to use if they are interested in a measure. So this scale measures attitudes and behavioral intentions, and it basically captures three main components of stigma that are pertinent to healthcare environments. Attitudes, negative attitudes, preference for social distance, and also healthcare providers' own willingness to disclose or seek help for mental health problems. So that gets at some of that self-stigma and kind of cultural stigma in the workplace component as well. So that was our first main step in our research. The second thing we did was we then engaged in thorough qualitative research with our partner programs to gain a better understanding of key ingredients, best practices, and other kinds of successful implementation strategies. And through that work, we were able to develop a process model. And I will talk a little bit about that process model today. Now, through all of this research together, we have also been able to identify a number of different successful programming models for stigma reduction and also some specific programs and tools that we have available for sharing. And I will also talk about those today. This map here just gives a bit of a sense of our various projects and partners across the country, across all four of our main target groups. So you can see we've got a pretty good breadth there. All right, so the first thing that before we kind of talk about solutions and tools is really getting a handle on the problem. So I wanted to spend a few minutes talking about stigma. What does it look like in healthcare environments, and what are its consequences for patients and staff? All right. So first of all, about stigma itself. By way of definition, the theoretical work on stigma really considers it as a complex social process. So we talk about stigmatization as a process that occurs through a series of kind of four main interrelated stages or processes. The first is the process of labeling, right? Using language that labels someone as different by virtue of their mental illness. Now that labeling, typically because of the connotations and associations connected to those labels, leads to the next stages of the process, which is a separation of us and them, and then also, very importantly, a devaluation of that labeled person. So this concept of devaluation is very much key to the process and to our understanding of what stigma really is. Now this combination of labeling and separation and devaluation is what then in turn really ultimately leads to status loss and discrimination, right, which is the behavioral outcome of stigma. And now the problem, of course, is because of the stigmatization process and everything that kind of backs up the discrimination, these negative behaviors can often be perceived as normal or even justified. So for more practical purposes, we can also define stigma as a problem of knowledge, attitudes, and behaviors combined. So we know that to truly combat stigma, we have to go after all three of those components. Right? We need to improve attitudes, we need to improve knowledge, and we also very much need to improve behaviors. So the second thing we know about stigma in healthcare environments is that in healthcare particularly, the problem of stigma is often kind of hidden, right? It remains under-acknowledged and under-recognized in many cases. And we also find that oftentimes this isn't because people don't care about it, but it has to do with the true lack of awareness about the many subtle and often unintended ways that stigma actually creeps into and gets enacted into the day-to-day practices of providing care to patients with mental illnesses. So as you will see a little bit later on in the presentation, this notion of awareness raising and kind of finding the blind spots it becomes really important in stigma reduction in healthcare environments. We also know that stigma exists on multiple levels. We talk about three main levels of stigma. There's self-stigma, public stigma, and structural stigma. So self-stigma, we know, is a major factor that prevents people from seeking help for mental illness. We also know that self-stigma interferes with recovery and can certainly also prevent people from disclosing or talking about mental health problems, which we know is a key issue for workplace mental health. And healthcare environments are certainly no exception in this regard. In some ways, they may even be less tolerant. Public stigma is that kind of stigma that arises and gets enacted through interactions, right? It's the stigma that kind of exists in the culture through our attitudes, through our beliefs, through our behaviors. And whether we're talking about the culture of the workplace, whether we're talking about our broader society, or whether we're talking about the culture of care and patient-provider interactions. Structural stigma refers to the type of stigma that's embedded right into the structures of different organizations, right? So it's the stigma that's built into our processes, our policies, our ways of doing business. Now, most of the work that Opening Minds has focused on to date and most of the tools and the programs that I'm going to talk to you about really try to affect change at the level of self-stigma and public stigma. But just so you know, we are now starting to look more closely at how we might be able to make some inroads into structural stigma. So if anybody is interested in learning more about that, I'd be more than happy to chat with you offline later on. So now the other main issue is, of course, we know that stigma is a concern for healthcare quality, right? It has very real consequences for patients and for staff. We have considerable evidence that that speaks to how stigma is experienced by patients and how it impacts patients. And basically, stigma from a patient perspective refers to interactions that leave them feeling on some level devalued, dismissed, and even dehumanized by the people they have entrusted to care for them and to help them when they are ill. We also know that despite many healthcare providers not believing that they hold negative attitudes towards patients, there is a considerable body of evidence that shows the contrary, right? That negative attitudes and behaviors do indeed persist throughout healthcare and among all healthcare provider groups. These negative attitudes that we talk about include things like hostility, blame, believing patients will never get better, a tendency to assume the worst of patients, say in terms of their propensity for violence, for example, is one of the things that comes up a lot. We also know that there are behavioral aspects to stigma, such as problems with issues with dismissiveness and language use. And we also know that this stigma in healthcare environments does have real impacts related to access and care and also patient outcomes. And I'll just speak very briefly here. We've actually just recently published a paper that provides kind of a review of the literature on the many consequences of stigma in healthcare. And it also provides an overview of a lot of the work that is going on in Canada to combat stigma. So that paper is readily available. I'm pretty sure there's a link. Yeah, there's a link there that you can access if you wanted to take a read of that paper if you want to learn more. But really, there are four main areas where stigma has been identified as having negative consequences for care and outcomes. We know that stigma is connected to barriers and delays for help seeking. We know that it's connected to early termination of treatment. We know that it's connected to poor mental health care itself and also patient safety issues. And we also know that it's connected to poor physical care, for non-mental health concerns. Okay, so that's kind of a definition of stigma and what its consequences are. But the next question to ask is, okay then, well, where does it come from? And the slide you see now is based on our qualitative research. When we were out in the field asking our respondents about what they thought was important when it comes to stigma reduction, many of them responded to us by saying, well, if you want to know what works and what's important, first you really need to understand what the roots of stigma in healthcare really are. Like, you need to understand where these stigmatizing behaviors and attitudes are actually coming from. And our research identified 4 main issues, right? So basically that if you want to tackle stigma, what you really have to tackle are these 4 main concerns. That's what you're going after. So the first one is a pessimism about recovery, that many healthcare providers don't really believe that recovery is real, and they don't really believe it's probable. Now that in and of itself wasn't really new. That already existed in the literature. But what was new for us through our research, I think, is how this links to stigma. And it links to stigma via kind of an increased sense of helplessness and hopelessness among many healthcare providers, of feeling like what they do doesn't matter, and therefore less of a desire to kind of, they think it's not going to help, so a little bit, why bother, right? The second big learning need is lack of skills and confidence. Many healthcare providers, particularly those without expertise in mental health, say they don't know what to say or they don't know what to do. Now this contributes to stigma in that it can lead to feelings of anxiety and discomfort among healthcare providers, and therefore a desire for greater clinical and social distance, right? Basically a desire for avoidance. The third one is good old-fashioned lack of awareness of one's own prejudices, and I spoke to this a little bit before. So here, really, anti-stigma interventions really need to have that awareness-raising component that goes after those blind spots that help healthcare providers see stigma in a way that perhaps they didn't see it before. And the fourth one is a tendency to see the illness before the person. And what our qualitative research told us about this is that this problem or source of stigma, if you will, becomes particularly exacerbated in conditions where there are high levels of compassion fatigue and burnout. Now, a fifth point that we could probably add on here also is when we're thinking about stigma as a workplace issue, right? So that it becomes a question of workplace culture. How open is the workplace culture for acknowledging and supporting mental health? How open or accepting is the culture for acknowledging and supporting mental health? Now, interestingly, on our stigma scale that we use, the dimension with the highest scores, which are the most stigmatizing scores, and this is consistent in evaluation after evaluation, it's that dimension that measures healthcare providers' own willingness to disclose a mental health problem or seek help for a mental health problem. So I think that speaks not only to the self-stigma component, but it speaks to that workplace culture component. All right, and that now brings us to the question of solutions. And when we talk about solutions, we think about going after stigma from both sides. We think about it as an outward-facing problem, right, as an issue of patient-provider interactions and quality of care. But we also think of it as an inward-facing problem, as a workplace culture issue and a human resources issue. And so I'm going to speak to tools we have kind of on both of those dimensions. So the first tool is what we might call an implementation guide for anti-stigma programming in healthcare environments. So this is the process model that came out of our qualitative research. It aimed to identify best practices and strategies and also key ingredients for programming success. Now this model, you know, with its kind of full description of what all the different themes and components are, is published, and there is a link there, I think, to get to the paper, but it's actually not open access. I should mention that. So I would be happy to provide it to anyone if they are interested. We also have a program report from this research, and that is available on the Mental Health Commission website. The model itself looks a little bit different, but it's based on the same research, and it has basically the same findings. Now, the details of this model itself, I won't really go into right now because there's quite a, there's just too much in it to cover in the amount of time we have. But I do want to point out perhaps the section in the top right, which is called Build Program Using Key Ingredients. Now, through our qualitative research, one of the things we did was to identify program elements that were believed to be of key importance to include in an anti-stigma program. And we were actually able to validate these ingredients subsequently through a meta-analysis, testing them against our outcomes data from our individual program evaluations. So that little corner of the model has actually been validated. Anyway, what we found was this. We found, first of all, that the programs that included all 6 of these key ingredients did perform significantly better than those that did not. Secondly, we also found that when looking at the ingredients individually, there were 2 in particular that stood out as being especially important. The first one was emphasizing and demonstrating recovery. So really getting that message across that recovery is real, getting healthcare providers to see what recovery looks like, and making that connection for them that what they do really does make a difference. And that includes even the seemingly small things. The second ingredient was that of using multiple forms of social contact. Now, social contact as an ingredient for stigma reduction is not the same thing as typical patient-provider interaction. When we talk about social contact as a tool for stigma reduction, we're referring to a very specific kind of contact. It's where people with lived experience of a mental illness who are in recovery speak from their own perspective and really tell their story, right? They speak about their illness, they speak about their recovery, they speak about their life more generally, and they also speak about their experiences in the healthcare system. So they speak about negative experiences if they had those, but also, very importantly, they talk about what healthcare providers did well and what made a difference for them. And I really want to emphasize the point about the value of social contact and using multiple forms of social contact, how important that is in stigma reduction efforts. Because often in healthcare environments, this ingredient is looked upon as one that isn't actually that important. Right? We hear a lot the sentiment that, well, as healthcare providers, we talk to patients every day. We hear their stories. We know their stories. So this won't help us. So they often talk about dropping the social contact component of an intervention or a program. But that's exactly the wrong thing to do. The social contact elements are, in fact, among the most powerful and important components because they represent a fundamentally different way for healthcare providers to listen and hear and learn from people's stories and experiences. In fact, our belief and our experience is that the social contact component, when done well, can get at every single one of those core learning needs that are identified in the middle of the model. So I just leave that with you as a word of caution moving forward, that if you are interested in implementing strategies for stigma reduction, don't let yourself get talked out of using social contact and keeping those elements in there. Okay, so that's our process model. So that is considered kind of a tool for implementation and a tool for guiding the design and delivery of anti-stigma programming. The next thing I want to talk about are our programming models. And there's two models that I want to speak about in particular today and programs within those models. The first is our workshop model, and the second, which is our inward-facing model, is our workplace model. So I'll talk about the workshop model first. So what we call our workshop model are mainly kind of outward-facing programs, right? They're designed to enhance awareness about stigma in healthcare settings, increase knowledge, improve attitudes, and improve behaviors, particularly as they relate to patient-provider interactions and providing care. Workshops are usually short in duration, so they're relatively simple to implement, and they're pretty suitable for almost all different healthcare provider groups. We do find physicians aren't always as enthusiastic about workshops, but we do have a program for them as well that they do seem to participate in. Now, because workshop programs are short in nature, they're not really meant to be delivered as one-off programs. Ideally, you know, a one-off program isn't going to change culture, right? And culture change is the ultimate goal for getting rid of stigma. So ideally, we do recommend that workshops are implemented along with booster modules for that ongoing messaging and reinforcement of key learnings, right? And we do have booster modules available. Now, the main program within this workshop model is called Understanding Stigma, and it's one of our most evaluated workshop programs to date. This program was developed initially by the Central Lynn in Ontario, who's been just a wonderful partner of ours. And they have basically handed this program over to us and granted full permission for us to make it available completely free of charge to anyone who's interested in implementing it. So the core program is about 2 hours, and it's delivered in person. We do also have a 1-hour condensed version available. It contains both educational elements as well as social contact components that get at all of those learning needs and those key ingredients. The social contact components include a video that we provide, and we also encourage including a live speaker if possible. We have a full toolkit available for the program, which includes slides, exercises, a full facilitator guide, and we have a speaker training guide as well, and we have booster modules. Now, as I mentioned before, this program is one of our most evaluated to date. It's been delivered in more than 15 different healthcare sites across the country and to many different groups, right? It's been delivered in emergency departments, in community health centers. It's been delivered kind of hospital-wide. It's been delivered to mental health staff and non-mental health staff and to other healthcare provider groups more generally. And we've seen consistently positive results across these multiple replications and implementations. We do have a paper that's just been recently published on this program, and again, there is a link to it, and it is open access. So if you are interested in learning more about the outcomes of this program, I encourage you to take a look at that paper. So that's an in-person workshop, Understanding Stigma. What about web-based workshops? And we do have some tools there as well. First of all, we are in the process of taking Understanding Stigma online. We're currently adapting it. We're working with CAMH on this, partnering with them on this. So we're very excited about that, and we hope that it will be available by fall. And just a shout out to the audience, we are currently seeking partners for our initial pilot evaluation. So if you are interested in helping us out with that initial cohort, please absolutely do let us know, because that would just be wonderful. So we do also have an accredited web-based delivery course that was designed primarily for physicians, although it is open to anyone who is interested in taking it. And we are finding that about half the participants taking this course are physicians, and the other half come from a whole variety of other backgrounds. Now, this course is hosted on the MDCME website. It actually is just going through the process of reaccreditation right now, so it should be available again soon. In the meantime, we also have another online course also hosted on the MDCME website, and I think the link is there that can take you right there. It's called Destigmatizing Practices and Mental Illnesses for Nurses and Allied Health Providers. It's a long name. But anyway, it was adapted from the Combating Stigma course for physicians and designed just to be a bit more specific for nurses and allied healthcare providers. But again, it's open to anybody who's interested to taking it. And our evaluation, you can see there, our evaluation results for the Combating Stigma course have been quite positive. And these online courses are all free of charge as well. Okay, so that's a bit of an overview of our the workshop model and some programs we have within that model. For the last few minutes, I want to talk about the other programming model we have, which is more of an inward-facing focus, and that's our workplace model. So for workplace programs, the objective is really more about workplace culture and workplace mental health, right? We want to reduce stigma as a workplace culture issue. We want to increase help seeking among healthcare providers themselves, and we also want to help improve mental health resiliency and coping skills. So we have two main workplace programs, and both are variations of the other. We've got the Working Mind, which is designed for more general workplace settings. It's a little bit more generic, I guess. And R2MR, which stands for Road to Mental Readiness, is designed to specifically target first responder populations. So just a bit of background on these programs. R2MR was the original program, and it was developed actually by the Canadian military. And we learned about this program a few years ago, which the military had evaluated extensively and to very encouraging results. And so we asked them if they would allow us to adapt the program for other first responder and workplace populations, and they agreed. So we partnered with them and the Calgary Police Service to adapt the program initially, and it's just really grown from there. So we now have R2MR versions for police, for firefighters, for corrections, for paramedics, and we also have a version for frontline health providers in the works as we speak. So that is being done in partnership with Ottawa Hospital, and they're going to be piloting the healthcare version of R2MR with their emergency department staff and their ICU staff. And we hope that the program will be available for full rollout in the fall sometime. Now the Working Mind, which is the version for more general workplaces, is also perfectly suitable for healthcare environments, and it has also been used in healthcare organizations. The largest rollout within healthcare to date, I think, has been with Capital Health in Nova Scotia, where it was delivered to about 300 staff and managers there. So the core program itself is a half-day program. It's delivered in person, and it has four main components. We teach an anti-stigma module, we teach a resiliency module, we teach a module on the mental health continuum, and we teach something called AIR, which stands for Ad Hoc Incident Review, which is really a technique for dealing with kind of sudden intense events that might occur in the workplace. And we also have a supervisor-specific module. So supervisors get the core program plus an additional module that is very specific to their role as supervisors, that kind of helps get at that learning component of, you know, what do I say, what do I do, right? How can I support my staff? So the supervisor program ends up being a full day. Now I'm just going to show you one piece of the program, which is the mental health continuum model. Now this slide is not actually the continuum. This figure shows more what a common perception is of how we often think in our default about mental health and illness, right? That basically one is either healthy or ill. But of course, the reality is not so simple. So we provide this continuum as kind of a better way to think about mental health and mental illness. And we teach kind of four main things about this model. First of all, we emphasize that mental health is not a dichotomy, but it is a gradient or a continuum of both mental health and mental illness. The second thing we teach is that the arrows along this continuum absolutely move in both directions. So if someone ever does find themselves in the orange or the red, we know that we can always get back to the green, right? So these things move in both directions. The other thing we emphasize is that the continuum model actually gives us another way of conceptualizing and talking about mental health and mental health difficulties. So we can speak in colors and indicators, which allow us to get away from labels and language that might be stigmatizing. So in this way, we actually see the continuum itself as a bit of a stigma reduction tool in and of itself. Now, each phase or color of the continuum is accompanied by a set of signs and indicators, and those signs and indicators are used to, are used to help people kind of gauge where they're at. And we also emphasize that the continuum is not meant to be a diagnostic tool. It is really just more a way to help staff self-assess, gauge where they're at, and then really importantly, just to make it easier to open up conversations with their peers, with their supervisors and coworkers about mental health, right? Again, it's a tool that can help facilitate that cultural change that we're ultimately hoping to achieve. All right, now just a quick overview of some of our evaluation results for the Working Mind and Road to Mental Readiness before I hand off. So for these programs, we actually include a fair number of indicators. We measure stigma reduction as we do in our other healthcare provider programs, but we also measure increases in resiliency, and we measure knowledge gains regarding mental health in the workplace. And what we're seeing again are good, solid results across the board. In fact, most of our effect sizes for improvements are in the medium range, which we take as very encouraging, given that the program is still on the shorter side, right, as a half-day program. And here is a brief just taste of the type of qualitative feedback we tend to see from these programs. They tend to be very well received. Staff definitely appreciate and find value in the continuum and in the resiliency skills that are taught. And the anti-stigma module also seems to provide some valuable learning and awareness for them as well. And just so you know, as well, we are in the process of developing booster modules that will be kind of online delivered for both the Working Mind and the Road to Mental Readiness. Now, we are in the process of preparing final evaluation reports with our pooled data for both the Working Mind and R2MR, so we will post these on the Commission website once they're complete. And we're also preparing papers for publication on these programs. So if anyone is interested in having copies of those when they're available, just let us know and we can certainly let you know. So I'm going to leave it there for now. I would just say thank you very much. Yeah, thank you. And I will be back at the end.
Yes, absolutely. And one of the last slides at the end of this deck does include Stephanie as well as Romy Christie's contact information. And time permitting, we will be posing a few questions that are coming through to Stephanie. But first, I would now like to turn things over to Jennifer Kitts to talk about the Mental Health Commission of Canada's and Healthcare Can's partnership in advancing workplace mental health and healthcare, and the By Health for Health collaborative work. Jennifer will then be handing things over to Sandy Coughlin to learn more about a new declaration initiative that's just been launched. So with no further ado, Jennifer.
Thank you so much, Sandra. I'm delighted to be here to provide some information about the By Health for Health collaborative that began about over a year ago that works to advance psychological health and safety in healthcare settings. So as Sandra mentioned, the Commission and Healthcare Can have had a collaborating relationship for many years, and this collaborative venture was very much a logical extension of our work and ongoing partnership. It was formally launched last June in Ottawa at NHLC. There are currently over 20 organizations that are members of the collaborative from across the country. These members represent about 270,000 employees across the country. It can look like a small group, because I know there's people on the call today who are from institutions and leaders across the country. But currently, as a group, we are considering how to broaden our work in our community. But we also have to balance this with our financial and organizational capacity issues. But we'll very much look forward to keeping connected with you as our thinking and planning evolves on the collaborative. The goals of the collaborative are several. First, we very much work to support our collaborative members to implement the standard on psychological health and safety in the workplace. Some of our members are further ahead than others, and it's very much a mentorship opportunity, sharing tools and resources and best practices. Importantly, as a group, we're very interested in systemic change at the national level. For example, working closely with Accreditation Canada to try to embed the standard into accreditation processes, for example. We are also developing tailored and relevant tools and resources for the healthcare sector. And finally, we work together to influence health-related organizations across the country to take action around psychological health and safety in the workplace. The collaborative has developed an action plan that aligns with this vision. The vision is before you, namely that healthcare workplaces will be leaders and role models in providing psychologically healthy and safe work environments for all Canadians. As mentioned, it's led in partnership by the Commission and Healthcare Can, but it's very much our collaborative members that are really driving this work. So at this point, I'm delighted to turn it over to Sandy Coughlin, who is one of our member co-chairs of the collaborative, along with Matt Snyder. Sandy is the Director of Occupational Health and Safety at Providence Healthcare in Vancouver, and she's going to talk a little bit more about the action plan and our newest initiative that was just launched this month. So over to you, Sandy.
Thanks very much, Jennifer, and I am absolutely thrilled to see the number of participants on this call, understanding that this is a critical piece of work that needs to be done in healthcare, because apparently in healthcare we're different than every other segment of Canada, and mental health issues don't impact us. And of course we know that's not true, and that's one of the reasons the collaborative came together, and we're grateful for the support of both the Mental Health Commission of Canada and Healthcare Can. So as Jennifer mentioned, we got together about a year ago, just over a year ago, representing a huge number of organizations across the country, and we worked real hard on determining where did we actually need to focus our attention, because it's kind of like herding cats. There's lots of different things you could do, but where were we going to best use our resources for a limited period of time, which is where we came up with the 3 focus areas that you can see on the screen now. As Jennifer had mentioned, the organizations are at a variety of stages along implementing the national standards for psych safety in the workplace, from not having done anything at all yet to having implemented some of the risk factors and some of the standards. So it was really important that we were able to bring into one area the ability to share information, because if you look at the national standards for psych safety and realize that this is a huge amount of work, it can be very overwhelming. We needed to make sure that everybody knew we're all here to help each other out, and nobody's starting from scratch all by themselves. So when we're looking at the mentorship and knowledge exchange, that's what it's about. We are looking at bringing together the best tools and resources to implement these national standards, which is really a psych safety system. Because there's a lot of great information out there, but you have to sift through and what actually works in healthcare, because healthcare is a unique environment. We are not dealing with things, we are dealing with people. We are dealing with people at their most vulnerable, and it can be very, very challenging. We've got compassion fatigue, resilience is down, vicarious trauma, you name it. It's a big struggle in healthcare now. And, as I said a bit earlier, when we think that we're different, that's where the system transformation comes in, because we really do have to remove the stigma and put the focus on that we have to look after ourselves in order to provide good patient, resident, and client care. So it's kind of a big deal to do all of this. So when we looked at, I should advance the slide here. So when we looked at what does this actually mean, and how do we show that we are the leaders and the role models for how this work should be done in a variety of industries, this is where we came up with what we're calling the declaration. And as it says on here, it really is a public commitment. We're saying that we do value our folks, we do know they're important, and we are committed to taking the actions to improving the work environments. So that doesn't mean that when you sign on to something like this that you're saying we're doing it all and we're doing it all right now. What it says is that you are committed as an organization to making the workplace a better place to work, a healthier place to work from a psych safety point of view. And it really, you know, it's quite a statement out there. I know when we signed on to it and then changed the signatures to include it in our as we send stuff out, lots of questions came up. It's a really big deal to do this. And it really shows, this is like most folks, it's their CEO or someone very senior that is signing this declaration. And it really just says to your own folks and to others, this is the commitment that we're making, and it's really important to do this. And I think the biggest thing, one of the biggest advantages to signing on to this is that you're accessing a whole bunch of resources that might not be available to you otherwise. You can search all kinds of different places. We're putting everything in one place. So signing on to this, when we're saying join the movement, signing on to this says that you're making that commitment to your people. You are showing them that even though you may be at the very beginning of the journey, you are willing to do this work. You are willing to show them that they are important, and this is a critical thing that we need to do. You know, when you join on this, when you sign on it, you get this lovely certificate that you get to post, that you get to do outward facing to the organization and inward facing. Everything is on the Mental Health Commission's website. All the information that you need on there. This declaration is on there, what it means to sign up, why you should sign up, why you should join the movement and be a health leader is all on the Mental Health Commission's website. And I would really urge anyone who is considering it and has questions, go to that website and have a look-see as to why you think it's important. The other thing that's on that website that's really important is that lots of us who have already signed on, we've got the statements that said why we're doing it. Why did we do this work? And keep in mind that all of us are at different places in this. As I said, some of us haven't started. Some of us are way further along, have all kinds of resources. Michael Garron Hospital is a great example of that. But it just is a commitment to say, this is important work. We want to do it. We want to work together. We want to tap into the resources that are out there already across the country that are being pulled together through the Mental Health Commission of Canada and Healthcare Can. So that's kind of my sales pitch here because I believe passionately and strongly in this, and I'm absolutely thrilled to be able to be a part of this work on an ongoing basis. So that's probably about all I have to say. We've already had about 18 signatories, at least on here. People are signing up all the time. And I just encourage you all to consider it with your organizations, look at what it means to join it. You know, any questions at all, contact the Mental Health Commission. If there's questions that I can answer or my co-chair, Matt Snyder from Peterborough Health, can answer, then we would be thrilled to be part of that conversation. So that's it for me at this point in time, but it's just an awesome initiative. So encourage you to look forward to it.
Great. Thank you so much, Jennifer and Sandy, for talking about this great initiative. And it was recently just launched, and we're going to continue to move forward with it and you know, promote it in the months and years to come. So please do visit our website for information, and also feel free to get in contact with any of us. So again, thank you so much, and thanks for being such great champions in this important work. Okay, so now before we wrap things up, we do have some time for some questions. One, I'll go back to Stephanie. And one question that came up during your presentation was, did you include public health practitioners in your healthcare providers research?
Oh, yeah. You know, we did. We didn't have public health organizations per se, but certainly we included public health workers within organizations, right, within hospitals and that kind of thing.
Okay, great. Another question related to your work is, can any learnings that have been applied through the work that you've done to date be applied to other sectors, or have there been that you know of?
Well, yeah, I mean, it's very interesting. When we started our work, you know, we kind of took this targeted approach where you know, we wanted to, because we weren't sure if, you know, that apples would be apples across the board, right? That what the needs were in healthcare provider organizations might be completely different than the needs for, say, youth populations or seniors or, you know, whatever. But what we are finding is that there are some real consistencies and overlaps across the different, you know, across the different groups. So absolutely, some of our learnings do seem to be, you know, kind of more widely applicable, like the value of social contact, for example, as a strategy for stigma reduction. I think what we're learning, though, is that, of course, the story that is told and the actual content that goes into somebody's personal testimony, the more it's kind of targeted to the actual audience, the more impactful it's going to be. And the other thing that we've learned as well is the more, so for example, in a workplace program, the social contact component is really about getting a fellow healthcare provider to speak about their experiences and their story. So you're getting at that, you know, what is my experience from as a fellow healthcare provider, as a peer, as a workplace issue. Whereas when you're doing, when you're focusing more on the outward-facing issue, the story, the social contact component can is, you know, works from having like just a patient perspective, right? So I guess we're learning that, you know, there is that there's a lot of the same principles that apply across different groups and can be applied to different groups, but just with some adaptations and modifications, if that makes sense. I hope that answers the question.
Thank you, Stephanie. Also related to your research, have you looked at it yet from maybe that sort of Northern Canadian context?
You know, we haven't, but we are in our youth in our youth research, working with Aboriginals and First Nations is one thing that we are really starting to focus on, and so that part is growing. In the healthcare provider research, we haven't really been able to take a look at the northern context so much. It's a challenge, but with, you know, but it is certainly on our list, right? It's something we want to focus on more and direct more attention to.
Okay, great. Thank you. One more question for you, Stephanie. Is there any evidence to support whether training in the workplace is more sort of quote-unquote impactful if it's given by a colleague or say sort of through maybe a train-the-trainer type program in-house versus a third party coming to and providing training? Do you know anything about that?
We have found, like in our programs, that that a train-the-trainer model works quite well. Actually, and in fact, when with our Understanding Stigma program, when it first was delivered and implemented, it was being delivered with kind of expert facilitators, so people brought in kind of from outside who are expert facilitators. And what they kind of found was like, you know what, it might almost work better having somebody inside the organization or somebody who's really truly passionate about this stuff. And in fact, that's what we identified as one of our key ingredients, right, is having that passionate facilitator who really can model and lead that person-first approach and that really anti-stigma messaging, who kind of embodies that. So I think it's not so much about whether you have an expert from the outside or somebody from within. I think that both work, possibly even better somebody from within if you get that right person, right? Because then you're just more guaranteed to get that right person.
Great.
Who's really
Thank
passionate about it.
Yeah. Great. So also we just we're getting a few questions also related to the declaration that we're happy to answer even, you know, offline as people maybe are looking at the website and trying to you know, maybe I guess, navigate around that. But in general, there is no cost associated with this. It is sort of a free initiative. Again, it's more about the sort of promotion and drive to, to that commitment at the organizational level, as Sandy was speaking to, and that it really is a healthcare provider kind of specific focus for this specific initiative. And again, it's not tied to any other program. Like Sandy was saying, there isn't now this commitment that you have to sort of sign up to some other program. If you read the language online, you'll see that we kind of come with the notion that it's aligning with the national standard for psychological health and safety in the workplace and the principles of that standard. Again, it doesn't mean that now by signing you are now sort of publicly saying that you're now adhering to all elements of the standard, though we do strongly encourage that. Those of you who know, that the Commission strongly supports use of the standard overall. But again, it's more just at that higher level, publicly committing to wanting to advance psychological health and safety within your workplace and your workforce is really the essence of that, and again, with that healthcare and healthcare provider focus. So hopefully that clarifies some of those questions. And then again, you get access to the emblem that's specific to this initiative, and then it's something that we've heard from those champion organizations that are already happy in using it. I think Sandy has it in her email signature now. Use it for your HR recruiting practices. Maybe it's strategic for different parts of your website as well, or some of your communication that, yes, once you have publicly signed that, then you can go forward and sort of promote yourselves and your commitment to that where you see fit as well. So we strongly encourage that. And with that, we're just going to move on now to reminding you of when our next webinar will be. So as always, we are taking a bit of a summer hiatus, I guess for our own workplace wellness as well. So there won't be a webinar at the end of July, but we will be back again in August. So we don't take too much of a break, but please do look for the emails or sign up for our next webinar starting in August and into the fall. And also, as always, please do keep in mind that we do have a survey after you leave this webinar, and we do value that feedback and use it for our planning and quality and all those purposes moving forward. So please complete that. And with that, I really just want to take a moment to thank our great speakers today. Stephanie, thank you so much, as well as Jennifer and Sandy for speaking to the great work that we're all doing together, and it really is a pleasure working with all of you. And I hope that those on the line got something out of this, and that we will in a few weeks be having our this webinar posted online. And then you're free to share it amongst your networks as needed. And with that, I just want to say happy summer and thank all of those with me today too that are behind the scenes, Jane, Laura, that really make all of this great work happen. So with that, I just want to say thank you and enjoy the rest of your day.